welcome to West Virginia Junior College. This is our lab. My name is Chelsea. I'm our medical program director here. Today we're just going to kind of go through and show you guys like some stuff that we do in the lab, kind of like some vital signs. We'll do some EKGs, a strep test, work on injections. We may do like a little ear cleaning, an ear lavage, and we're going to do some phlebotomy. So we're going to show you guys kind of how it works and how we do our education here. And do please remember, this is for educational purposes. We are learning. They are not in the field yet. So if you have any comments or concerns or maybe even some suggestions for us, we'd be more than happy to take those. But do please remember, we are learning in this class. So these are students. They are washing their hands right now. So first we always start out with medical asepsis. We want to make sure we do wash our hands and we keep it, as clean as possible. The first thing we're going to do, we're going to do an EKG. So if you guys want to follow me this way, we are going to have our patient here. So as a medical systemist, so you guys know, we don't typically read or interpret EKGs. We mainly perform them. And depending on what kind of setting that you work in, depending on the hospital or, a regular office, it may be different everywhere. All EKG machines are different as well. So the one we have here, it's a little older and a little different, but it still does work the same. So this is Joey and John. They are the ones that's going to be practicing today. So Joey's going to go ahead and place his leads on here, and we do know there are different places you can actually place the electrodes on the body. So he's going to put them here on the arms, which we also know they can go on the inside of the wrists, is where I like to put them, preferably for myself. He's going to find the fourth intercostal space there for the first two leads for 1 and 2. And then all those other leads are going to go here on the left side of the body. So he's going to put those on there, and we'll let him get all those up on there for us.
Just remember, the camera ad sent out. Let's do this next.
So we also have two that's going to go down here on the legs. The right leg is our ground lead, so technically our EKG wouldn't work properly if we didn't have that one on there. So he'll put those. And we're going to scoot back just a little bit, John, so we can have you lay back. Our bed doesn't go quite in the semi-Fowler's position, so he's going to be laying pretty flat, which I don't really like, but he can't lay any other way right now. So he'll be fine down there for a few minutes. So Joey's going to go ahead and hook him up here. While Joey's doing that, a lot of times whenever I know I'm in the field, I like to tag team on this. So I like for someone to work the machine and get all their information in while somebody's hooking them up. And I'm sure Joey can attest to that. He is an EMT, and they do, if they have two people in the back, they do try to tag team this, or even if they come in and pick them up from an urgent care or an office or something like that. Typically they're going to go ahead and hook them up to the EKG machine right then and there to make sure that everything's working properly. So we like to have, two people if we possibly can to get that done. So I'm going to go ahead and get his information into our EKG machine. So he is technically a new patient today. We'll see that. I'm going to put his name in here. Can I have your full name and date of birth, please?
Yes, my name is John. Oh, yes, my first name is Easter. Last name Bunny. Don't tell the kids, that's a secret.
Okay.
I was legit the Easter Bunny. They can testify.
What's your birthday?
April 15th, is that Easter?
Something like that.
Close enough. I'm sure it was Easter one.
Yes. 1000 BC in the year of our Lord.
Okay, like it. Oh, it wouldn't let me put that in.
Oh, sorry. There's probably not a BC button. Any days.
This is an EMS. We're not.
I'll be in 1940.
All right. So once we get that in there, as soon as he gets him completely hooked up here, we'll be able to start our EKG and print that off. Once it's printed off, what we typically do is we hand it to our provider, whether it's a doctor, nurse practitioner, PA. They're going to read it and interpret it, and then they'll either let us know if we can unhook the patient or if we need to run another one. Our job mainly is we're looking on the machine to make sure there's no artifacts. So an artifact pretty much means that there's something on the EKG machine that I can't read it properly. Something is unfocused, and I can kind of show you guys really quickly right now while he's moving around. If you look there on the EKG machine, you can see all these wiggly, baseline here. It's going a little crazy. That's because he's moving, and it shouldn't look like that. We want to wait until it looks perfect all the way across before we print it out and make sure there's no artifacts. So that's pretty much our job. That's what we're looking for, to make sure it looks good before we print it off for the physician. If it has artifacts, they can't read it properly, and then we're going to probably have to perform another one. My rule of thumb is, just from working in the field, I always wait until the provider looks at it before I take it off of the patient. But then again, this is also, it may vary depending on where you work. So we're going to let that print there. Looks good. I don't see any artifacts on there. So, and for some reason ours prints twice. Not all of them do that, but I'll let you pull it off and kind of show what we did there.
No tombstones, right?
Nope. No heart attack. I think you're good. So this is the end product. This is what we're going to give our physicians here. And that's it. And then what Joey will do is, once he showed that to the physician, he's going to unhook the patient, make sure, they feel good, and set them up slowly, and they're typically good to go. This here is Matthew and Ella. So Ella is going to be our phlebotomist. She did wash her hands before, just so you guys know.
Twice, actually. So I'm going to be doing a butterfly needle stick today.
And Matthew has very good antecubital vein. So the antecubital vein is right here in the middle of the arm. Typically we want to stay away from the inside of the arm. This is the basilic vein. This has an artery that typically lies right underneath of it. Now you can feel on the patient's arm. If you can feel the pulse there, we definitely don't want to use that vein because it's very close and you could hit the artery. But sometimes people's veins don't always lie right over top of that artery. So you just have to pick and choose on your patient. They're all different. And then we can use the cephalic vein over here as well. It's just not, it's not as good as the median cubital vein here. This is a bigger vein. It's anchored more properly, and it's typically easier to get. Also, you can use the hand veins. We don't want to go really typically down here in the wrist. You can use this one as a last resort, but there's also a big nerve that lies in there. We don't typically want to use that, maybe for IVs, but not typically for a blood draw. And then up here, we can use these veins as well. I don't really see good ones in Matthew up here. He has an awesome median cubital vein that once Ella ties on the tourniquet, you'll be able to probably see it poke out. So we'll let her do her thing, and you guys can kind of watch her as she proceeds through this. And if you guys have any questions, let us know.
We got Pam Cole saying hello to you all, just so
Hi,
you know. She's watching. She said, Matthew, get to work.
I'm on vacation.
Did you hear that, Pam?
We also have a Gloria.
Oh, good morning, Gloria.
Gloria. Good morning, Gloria. So she has wiped him off. She cannot touch the site again because if she touches it again, it'll be, unsterile. She is going to anchor down the vein here. So she's going to pull down on the skin just below. And there's different ways you can do this. You can do it kind of to the side, or you can do it, down below. It just depends on your preference. And remember, not every technique is done the same. Everybody does things a little differently, especially whenever we're learning. And she did, however, get blood. These needles also are very small. I think these are 23 gauges. That's just the only ones that we have here at the moment. So the blood's not going to come out as quickly because that needle's pretty small. So, but she did, however, get it. She did the proper thing. She popped her tourniquet. She took the tube out. She's having the patient hold his gauze and fold his arm up and go Ella.
Nice job, Ella.
Christina said, "Go Ella."
No-
So we're gonna do another blood draw. This is Amanda and this is Aijane.
Hi, baby.
Have you looked yet or? Oh yeah, go ahead. So she's gonna actually look for the veins. So typically before we even start to do a blood draw on anybody, we're gonna find the best vein that they have. We always look for the median cubital vein first, which is in the antecubital space right here on the other side of the elbow. And then once we find a good vein, we're gonna typically try to go for that one. We like to map it out. So if she does find a good vein, she wants to use site locations to remember where the vein is. So she doesn't have to, try to touch it again or anything. And you will see sometimes phlebotomists pull off the tip of their glove and like wipe their finger with alcohol, or maybe even wipe the tip with alcohol. I don't typically recommend that, but sometimes if the vein is really, really hard to find, you may have to do it. And I'm sure everybody has probably seen that happen before. It's not, horrible to do, but we try typically not to do it. All right, so let's see. Let me see this one. Aijane is a hard stick. She has really deep veins, so sometimes she's a little harder to find one. So we'll try to get over here. Sorry, Aijane, I'm tied a little tight. Try to get your vein. Squeeze your fist. Right here. I'm probably gonna have you scoot that tourniquet just a little bit. I'm gonna try to. Alright, I'm gonna untie her tourniquet. Let her get her stuff ready. Are you doing a butterfly or a straight stick? Butterfly. Okay. You like the butterfly?
That's right.
I am a very hard sticker.
Here's the thing, if you think about it, technically, the reason why we use a butterfly is on small veins because they don't have as strong as a vacuum as a straight needle does. Also, really, the needle is the same thing. If you have a straight stick that's the same gauge, they're actually the same type of needle. It's just the vacuum that comes out. So the butterfly just doesn't pull out the blood as fast as a straight stick does. That's the only thing. A lot of people get scared of the straight sticks so they're intimidating and the needle looks really long and big. Really, it's the same. It's just the vacuum on it that's different on the two different types of needles. So a lot of people are like, oh, I need a butterfly. I have to have a butterfly. They do have really small veins. It probably is better for them to have a butterfly, but if their veins are like real thick and big, then you could use a straight stick. All right, so let's do me a favor. I'm gonna have you re-wipe her off. I'm gonna have you tie the tourniquet on her first, and then wipe her off again. Your vein. So for Aijane, you may have to go at a little bit deeper of an angle than you typically would because that vein is pretty deep. So when you go in, kind of angle it more. Not straight down, but angle it more than you typically would.
Miss you too, Sarah Marsh. She's saying she misses you guys.
Hi, Sarah. We miss you too.
Yes.
No, you're fine. So typically, whenever you're in the field, you don't want to leave the tourniquet on for longer than 1 minute. But while you're learning, it is okay to leave the tourniquet on it's okay to leave it on for longer than 1 minute. Why? Is because we're not actually running this blood. We're not sending it to the lab. So what typically happens is this thing called hemoconcentration, where the blood kind of, builds up in one area. Now, while we're doing this, it doesn't really matter. This is just for practice, so you can leave the tourniquet on, a little bit longer. We don't want to leave it on too long because we don't want to hurt our patient here, but it's not going to hurt if we leave it on longer than 1 minute. But typically, we don't want to do that, so she's going to pull the needle, or pull her skin down to anchor it again. She's going to go in. Yeah, I would like that. And stick. Hold that, and we can go with that hand over there. You may hand it to you. So we didn't get a flash, and that's okay. It doesn't look like she may have missed it just a little bit, and that's okay. I kind of see like a little tiny bit of blood. Pull it back just a little bit and go down with the butterfly needle. Like let it go flat. There you go. I'll pull back just a little tiny bit. That's okay. And we don't fish in this class. I don't let them move the needle around more than just going in and out a little bit. We don't go side to side or anything like that. So if we miss, that's totally fine. That's why we're learning. We're trying to figure out, where are the veins? How do we get the veins? And if you'll show them really quick how to activate the safety device on there. We do practice safe engineering controls and stuff like that. So we want to make sure that we do activate our safety device every single time after we use a needle. No matter what, we always do that first, and then we make sure we throw it in the sharps container over here, and we are good to go. Good job, guys.
Nice work. We had a volunteer.
With a strep test, I like doing strep tests, in the field, because these are standalone orders. If we have a patient come in, they're signed in, they come to triage, and they tell me they have a sore throat, I don't need a doctor's orders to do that. I can go ahead and just do a strep test on them. That's because typically the doctor's going to want us to do a strep test on them, and when we do that, it makes the doctor's life a little bit easier. The doctor's going to like you if you can make their life a little more simpler and go ahead and get things done without them having to tell you. So strep test is one of those. So anytime you have a sore throat, you're going to want to go ahead and swab them. So what we're going to do is, these are our reagents here. So we're going to do 4 drops of each of these. We have an A and a B, and I'll go ahead and do those, and I'll let you do the swab. So we just take one of these. Sometimes you'll have a whole family come in, and they all have a sore throat, and you have to do this. So the way I do it is, I take these little tubes here, and I take a Sharpie, and I put their initials on it, so I know whose is whose, and I don't get them confused, because a lot of times, 1 or 2 of them will have strep, and then the other ones won't. So I need to remember whose is whose. I also write their initials on the packets as well, so when I put the little swab back in there, I know whose is whose. So we do 4 drops of each. So we'll do 1, 2, 3, 4. And I do want to say, before you actually do this, you do have to do this thing called a quality control on these type of tests. We call it a QC. Pretty much what that means is we're making sure that this test kit's working properly. So if it doesn't pass the quality control, I cannot use it on a patient. I can test it up to 3 times. If it doesn't pass the quality control, you get a hold of the manufacturer and you send it back and tell them, hey, my strep test isn't working properly. Can we get a new kit? Typically it has to do with like the lot number, and those all normally don't work, but typically we don't have a problem with that. The reason why we're wanting to make sure it works is we want to make sure our patient is tested properly and that it works properly on our patient. So if the QC doesn't pass, then obviously it could give us a false negative or false positive on our patient, which we don't want. So we want to make sure that it works correctly, okay? So what Micah's going to do here, she's going to swab the back tonsils. So she's going to have her patient open her mouth, stick her tongue out and say, ah. That way we can get all the way in those tonsils. Avoid touching the tongue and the cheeks and the teeth. We want to just get on the tonsils. If your patient really does have a sore throat, they're going to typically have like little splotches and stuff. Good job. They're going to have little splotches and spots. You want to get those nasty little areas because that's probably where the strep is going to be. So Michael's going to put her little swab in here, and we leave it in there for a minute, okay? So it's going to sit there for a minute. We'll look at the time in about 50 seconds from now, we'll take it out. When she takes it out of here, I'm going to go ahead and let you hold it so we can show what we're going to do. Anytime you have a swab like this is with COVID. Flu swabs are a little bit different. They do sometimes come like this, but not typically. They're a little different. If you ever have a swab that goes into a reagent like this, you always squeeze it here at the bottom. So you're going to squeeze that, Micah, and you're going to twirl that around in there. What we're doing is we want all that bacteria to get off of there because that's where the strep is. So we want it to go in the fluid. That way when we stick our test strip in there, it's going to show us if it's negative or positive. On the test strip here, you'll have at least one line that pops up that's called your control line. That means that this worked properly, that it had the fluid go in there. We can tell that it is either negative or positive. If it's negative, it only has the one control line. If it has 2 lines, it means it's positive, and if there's no lines at all, then this is not working right, and we get it, or need to get another one. All right, so go ahead and take the swab out. We're gonna stick this down in there. We leave this in there for 5 minutes. So we'll set this in there, go do something, and then we'll come back and look at it and see if it's negative or positive. So over here, what are we practicing here? Stitches and staples.
Yeah.
Typically, as a medical assistant, we do not insert stitches and staples. You may have to assist with it by handing your provider things, such as the instruments. You may hand them the sutures, the lidocaine, stuff like that. But every now and then you may actually have to help do a stitch, or you may have to help do a staple or something like that. Sometimes we're there just to hold the patient's hand. Sometimes we're there to hold the patient. Sometimes we have to restrain them. Like if they're little kids, I've had to hold their head still, or I've had to hold their arm still, or sit on their leg and hold their leg still because they can't keep it still when they're kids like that. But what we'll do today, Joey's going to go ahead, and what he's doing now, he's getting on his sterile gloves. So he is doing that properly. He's, not touching anything, keeping his hands above his waist level. Now, this isn't going to be exactly like it would be in the office, only because we don't have the correct, setup for that. But what he's going to do is he's going to get that needle on there, and we may actually do this for the physician. We may get the needle holders and take the needle out and thread it in. Oh, do you need me to open it? And of course, this is, breaking sterile film, but we're just practicing. We're not in the actual office doing anything. Okay. Take that out of there. So he's going to put the needle on the needle holder, he'll do a few stitches, and then he'll take them out. So what we actually do a lot as medical assistants, we will take out stitches and staples both. You'll see a lot, especially in the gynecology office, if they have like C-sections and stuff like that, you're taking out all of those staples. Sometimes there will be sutures within those, or maybe there's butterfly sutures. We do actually take those out. We see a lot in ortho too. If you're doing any type of ortho, you see a lot. Some of my old students may have some stories to tell where they are. They're all in different places. They all work different, in different areas. They may do this depending on where you work. You may not do this at all depending on where you work, because some places don't, typically give sutures, give staples. It just depends.
Caitlin Allman says, my favorite teacher in the whole world.
Aww.
Hello, Caitlin.
Matthew Osborne says, let's go.
I've got a hi Chelsea from Taylor Blankenship.
Hello. People are getting married on me. I forget people's last names. Yeah, let's cut that off. It'll make it easier.
And Cole gave some vein phlebotomy tips in there.
Oh,
Ooh,
thank
what
you,
did
Pam.
Pam say?
She said, phlebotomy tip for hand veins that work the best is, and keep them from collapsing, is to draw with a 10 milliliter syringe.
Yep. So that is.
Nice.
You might have to start over on that one where it messed it up. So that is true. Typically, you'll see this a lot too. Phlebotomists, I feel like in the hospital are the best at this because they do it so much and all day long. Like if you work in like an urgent care or something like that, you don't get to draw blood as much as an actual phlebotomist does. So we gotta learn the little tips and tricks, but using a syringe is the best way to pull blood from a child and from hand veins, because you can control how fast you want the blood to come out and it doesn't collapse it. With a butterfly or a straight stick, we don't really get to control how fast that blood comes out. The tube is vacuum, so it pulls the blood out automatically. With the syringe, I can sit there and wait, however long I want to pull the blood out. So that is actually true.
Hannah Mooney says, best instructor ever. Hey,
Hi, Hannah.
Take offense to that, Hannah.
I was just thinking about Hannah the other day. I haven't seen her in forever.
Oh.
Get your damn 12 gauge. That's right. Make it happen.
Hannah said all of you are wonderful.
Thanks,
Thank you.
Hannah.
Don't make up for it now.
We love you, Hannah.
Don't let my being topless fool you. Very modest
Did you
person.
open these? Yeah.
I'm still
Turn
laughing.
around behind you and that thing right there and hand me the ones that are.
Not at you, but your joke. Your joke.
I can't.
I know.
No, open that one. Are there more 4 O's over there? Here you go. Here's the bad boy. So I'll do one and then I'm gonna leave it. So I'll take it in. And obviously this whole process would have to be completely sterile. There's, you can't reach over sterile field. I would have gloves on, all the things that we would actually do. But this is a fake body. It is not real, so I don't think we'll be damaging anything today. But we do typically try to, practice just like we would in the field. But, sometimes if we're trying to get something done real quick in here, maybe a little different. So there's your first one, and then I'll let Joey do another one. I guess Joey.
I like that.
That's my best friend today.
Ah.
I don't have any fingernails.
Think of Chewbacca.
Chewbacca.
It's cool, man.
Chewy.
I'll be your Han Solo.
So, so he's gonna put another one in. You're just gonna take those out, and we'll put some staples. Do we have any more staples in this body at all?
No, there's nothing back.
Okay. We like these little bodies here. They're so much fun to work on. They have all these little cuts and sores and stuff like that. We are actually still in lab 3, so these students in here haven't learned everything yet. Next week, or maybe by the end of this week, we're not sure. We're actually going to learn how to address wounds. So we're going to learn how to bandage them, clean them, all that fun stuff. Sometimes that's not for everybody because it can get a little nasty. But we will also do some colon health and stuff like that. So we'll be doing the guaiac slide test where you take a stool sample and you put it on the slides. And we actually use peanut butter, and I make somebody draw blood and we mix it together so you can actually see if it is positive or not. There's other ways that you can do it, but that's just the way I like to do it. And then what else will we be doing? We'll learn how to wrap. We're hoping eventually to get casting material in here. But it's kind of hard to get a hold of sometimes, but we want to learn how to put cast on and take them off. Unfortunately, I don't think we're going to be able to do that this 6 weeks, but we're hoping to maybe incorporate that into our labs here because we do send some of our students to ortho, and that's something that they'll be doing. So they can learn that on the job. They typically get on the job training for that, but I would like for them to learn it here so they already know how to do that. So.
We did practice with urine samples.
Yep, we do. We have done urine samples. Some of the other stuff we do in here that we're not exactly going to do today just because we don't either have it, readily available right now, or we're just not doing it. We do finger sticks, so we do hemoglobin tests, we do hematocrits, we do blood glucose, we do urine. So we do all typically the labs that we can possibly do that you're going to learn. When we do blood draws, we don't have a lab that we can send them to, obviously, so we just pretend to send them. We get a laboratory requisition form and fill it out, and we pretend to send it off to the lab. And I can't really show you guys how to do that, but I can tell you all how to do it. So that's something, when you get in the field, you're going to learn. If you use LabCorp or Quest or whatever outside laboratory that you use, I kind of walk you through the process of how that's done. So typically, you'll get a lab from a patient, whether it's a blood draw, a strep culture, or something like that. And then we're going to send that off to the lab. So there's steps to that. We have to process it into the computer, and we have to put it in a notebook or a binder. And of course, again, I like to say this because, I don't want, one-minded things. We like to be on a broad spectrum. everywhere is different. Every office is different. So you have to remember that in the long run. Not every, where does everything the same. Not everybody does everything the same either. We all have different techniques that we like to use. So maybe one way that you like to do something isn't another way that someone likes to do something. And that's completely fine as long as we're all doing it correctly. So that's what we try to work on here. I always tell the students too, whenever I'm teaching, I show them my way of how to do it. And then if they like to learn it another way, that's completely up to them. As long as it's getting done correctly, that's what we like. Oh, let's look at our strep test real quick.
Do we want to?
Yeah, John's
Oh
got
yeah,
to
let's
check.
do the injection.
Let's check our strep
Alright,
test.
so
And
we have a negative strep test. Yay, that means no strep in here. But this is what it looks like. I'll kind of show you guys. You see this line here, that's the control line there. And then on this side, we don't have a line. So just one line, that means negative. So we're good to go on that. Alright, so John over here, he's going to show you guys how to do an injection. What kind of injection are you doing, do you know?
I was actually gonna make a weevil.
Oh, okay.
I'm pretty good at that.
So technically he's going to do a TB test. This is not a TB syringe, and that is not a TB
Most
needle.
definitely not.
But
We do
we can
have.
practice with it. Let's see if I have one.
I think there's a bag of
So I'm gonna draw it out to about one.
oh,
You can still draw it up in there.
So I'll put a little bit of air in there before, hopefully, it won't fold. Not too many bubbles in there.
So this is not a TB syringe. I would
Yeah,
never
it's
give a
not.
TB with that. You're
I'm
going to
gonna
give it with
Put
this
the,
little tiny thing right here, but he can still practice in the fake skin with that as long as he's learning the correct angle and direction and where to put it in the skin. When we do a TB, we do it in the forearm, and we want to typically stray away from the veins and stuff like that. So we kind of map out the arm and make sure it just goes right under the skin. This is a dermal injection, so it goes right under, the skin there. So we made a perfect wheel, and it disappeared obviously because this is fake skin.
that's why I didn't put liquid
If
in
I
there.
were doing it
Top of my
possibly,
face.
I would hold my hand like this, not over top. I would put it underneath like this. So when I have, because it's only 0.1 is all that goes in the patient. It's barely any medicine at all. And I make sure that my bevel was up. Obviously, we would have cleaned it and, done all of that. We may have not done that right now, but we would do that, and he does know to do that. I don't have any fluid in here, so it's not going to do anything, but I would go very shallow and then push it in. I guess it kind of worked a little tiny bit. And then pull that out, and that's our wheel. And with the TB, do we use a Band-Aid or no Band-Aid?
Well, I was gonna use this actually. I'm sorry, I didn't get Band-Aids.
But
Well,
you
no,
don't actually use one with a TB.
Yeah, you want to be able to see the wheel.
Yeah, we don't use one. You can take a little piece of gauze if you want, because some of the medicine will leak out just a little bit sometimes, so you can hold the gauze over on top of it for a minute, but we don't want to use a Band-Aid.
Yeah.
Sometimes you will see people put a Band-Aid on there. You don't actually want to do that. You want to leave the Band-Aid off of there. Because it can cause irritation. What we're looking for is if they are positive for TB or not. And if they have a reaction to the Band-Aid, we could have a false positive, and we don't want that. So if somebody is positive for TB, we take them to get a chest x-ray and see if they have active TB in their lungs, or that's what we're looking for, is TB in there. But we don't want a false positive or anything from having a Band-Aid on there. If they're, what if they're allergic to latex or something and it makes it, swell or anything like that. So we want to leave it free. And with a TB injection, you come back 48 to 72 hours after you get it done. It can't be read before and it can't be read after. It has to be within that time span. Yeah, very strange, but that's just how it works. Go ahead.
We don't. I recap the needle. We don't do that. We usually put it sharps.
Yes.
But just because this is my syringe that I've used for practice. For practice, not for nefarious reasons.
Yeah. Typically, we will do the scoop method. So he'll lay the cap down and just like this, and he'll scoop it up on there, and then we'll throw
Just
that.
like raisin
Throw
bread,
that in the
2
sharps.
scoops ahead.
But when we're learning, sometimes we use the same one, especially if we're doing it in the skin. So we do know not to do that in a regular patient. So
Yeah, and you have different angles
yeah.
for injections.
Yeah, so we have, different angles, different type of injections. We have This is our 90-degree angle, so this goes in intramuscularly. So say it's in the deltoid up here in the arm. That's going to go 90 degree right in. Our sub-Q is a 45 degree. Could also be 90 degree depending on the size and the length of the needle. But typically it's going to go 45, and there's different places it can go in the body. It can go back here in the fatty part of the arm, and the upper backs up here in the butt, different areas. And then the one that he did, the TV, that's our intradermal injection, and that's the flat one. It's about 10 to 15 degree angle, and it goes pretty flat because it's just going right underneath the skin. We don't want it to go real deep into like the fatty or muscle area, but just under the skin there. So good job with our injections.
But basically we are removing the staples. So we're just gonna do this real quick.
And removing staples is super easy. Sometimes it does get stuck on the skin a little bit, so it may pull the skin, and you may want to like use some alcohol or something like that. But it does make these cool. This is one of my favorite things. I think it's so cool. It makes these little M's like this when it pulls the staples out, so that's pretty cool. This is. Well, I was gonna show you guys what a staple gun looks like, but I don't know.
Oh, they were open.
They're both empty, so they're back.
Yeah, they're empty. I don't have any staples, and then we've already used them on the patient. But this is what the staple gun looks like. It's pretty intimidating, especially for children. But I will tell you guys, children are the most resilient, and I swear they do the best with these. I've seen personally many of children have to get staples in their head with no numbing at all, and they always take it the best. It's like they don't even know it's happening. They just staple right along, and it really is awesome. It's amazing to watch. And then I've seen 50-year-old men get a cut on their head and they about die getting these done. So that's it's a lot of fun to watch. But it's also it sucks because it hurts. So yeah, so we wouldn't do these. The physician's going to do these. But you take this part right here and you line it up with the incision, and you just stick it on and you press this button and the staples go in. We're just empty because I use them all for practice. I think that about concludes today. So that's kind of what we do in here. Not on an everyday basis, but we try to get in here as much as we can. We do every type of lab we can hands-on. We're going to try to touch something in here, learn with our hands. That way, whenever you get out in the field, you're going to know what you're doing. At this college, we do an externship. So we'll send you out into the field. We'd like to put you where you want to go. And when you get out there, I like for you to know a little bit of what you're doing. So we try to get you as much practice in here as you can. When you get out there and you need more help, say you feel like you're not good at phlebotomy, or you feel like you're not good at something we didn't do in here, I'm going to practice that with you. You can come back anytime and we'll practice that. I have students still to this day that have graduated and they haven't worked for a while, and they're like, hey, will you let me come in and practice? Absolutely. We'll get in here, get your hands on, and get you ready for the job field. So that's what we do here. It was so nice to have you guys today, and for you guys to see our lab and all of my students here. And we hope you guys have a great day.
Bye.